Gupta Oration, and on this time we have to pay tribute to all our senior members who have led the burn care of our country till this date. The topic I think was suggested at the mutual discussion between Sridhata and myself, and she said instead of talking on a specific technical subject as that, you should speak on what we should do for the next 25 years. So the title was a strategic vision. And if you really see what the word means, it means that we need to think of a forward-looking and aspirational statement. I think that's very important. It's not just a statement, it's an aspirational statement as to what we want to achieve for an organization or for a country. And you need to have it as a timeline, and how do you have what is the roadmap for success. So my responsibility will be to make a forward-looking aspirational statement, defining the long-term goals for burn care in our country and how to... Oh.
Just a little bit, something.
That's off on the screen.
Yeah.
No, it's okay. Yeah, no, it's fine. It's not too bad. It does look good in here, so I can... So now we are in 2006. So when I thought of thinking for the next 25 years, I thought when I look back the 25 years. So 2026 means it's 2001, and then the other side is now 2051. And I looked at what was burns in 2001, and I got this article which was published in Lancet in 2009, which was, the title of the article was Fire-Related Deaths in India in 2001, a retrospective analysis of data. And the authors were from Boston, Harvard, and Baltimore. And they estimated that over 15,000, there were 163,000 fire-related deaths in India, which is about 2% of all deaths. And surprisingly, they also found that more than 1 lakh of these deaths occurred in women between the ages of 15 and 34. I think all of us know the obvious reasons why this number is there. And I also found, incidentally, one of the iconic institutions of burn care, led by Dr. Keshwani, it also started in 2001. So fast forward to 2006, I struck on this article in Indian Express on February 21st of this year, stating about a study that has been done by the George Institute of Global Health. And they said there are 2.1 million annual burns injuries in India. But then the death rates are only about 25,000. And then there is 1.4 million disability adjusted life years lost in India. This study has been led by the scientists of the George Institute, and is also co-authored by 2 plastic surgeons, one from the Jawaharlal Medical College, Aligarh Muslim, and our own Brijesh Mishra from King George Medical University in Lahore. Well, the 2001 article was in Lancet, and this 2006 was not only was a scientific study, but it also got to the newspapers. In addition to that, the newspaper also said, they did not just talk about deaths, but they also said the quality of life of the burn survivors, and it has been highlighted about what are the problems they are facing. If you see the change from 2001 to 2026, you will find the absolute numbers have increased, which is understandable because the population has increased. I think there's nothing wrong with that. But then the appreciable thing is the death rate is decreased. But all of them have said that the problem is the reliability of data in Indian conditions. I think that's a real problem all the time. But what really strikes is, while the article on 2001 dealt mainly on the death rates, 2026 article dealt on the quality of life, stigma of scar, lost opportunities, and even on the quality of care. They are even critical about the quality of care rendered by the hospitals and even on doctors. And it has also talked about medical gaslighting. I think many of you may not know the title of what is medical gaslighting, because it only says that many a time doctors poo-poo the complaints which are given by the patients. I think which is a very important part. So, but even the newspapers have started caring about this. I think that's particularly true because in 2026, we do face people like this, survived burns, but then lose the life of absolute cripple. If you see her neck is plastered to the chest, axilla is plastered, and if you see the hands, that's the left hand and this is the right hand. It's about, she has been living on like this for 4 years, but then she not only hits herself, but then the whole family is gone. I also found that more severe the deformity, the more likely they will find it difficult to access care. And they will be given dates after dates after dates, but then they never get onto the operating room. For them, the answer is today is the day they choose to come, and not the day that we can afford to take care of that. Of course, we have taken the project over to fire. We have taken the neck and the hand. We have corrected one hand, and through 5 surgeries spread over 3 years, all totally free to the patient. And last week we embarked on the surgery for the other side. Most of these patients fall outside the radar of the healthcare systems. We also have to realize that this is a word taken from the Aravind hospitals, their book, where they offer a lot of free surgery to the eye care. They said, just because you offer something people need free, it is not necessary they will take you on it. You also need to make the situations where they will be able to access your offer. I think that's very important. It's not like a cat that you just come in and go. But whereas if you are trying to take care of the hand like this, that means somebody else, another person in the family has to be there with us for 2-3 weeks. So I think that's where the need comes. Now, in 2026, we have a huge backlog of burn survivors requiring a reconstructive surgery, rehabilitation, and social integration. Now we go on to 2051. Predicting with a crystal ball is very difficult. I wish we record it and then we'll see someone plays it in 2051 and finds out what we have predicted is true or how far we are. But anybody makes a prediction, I think, will be biased. I think because he uses his ideas and his experience and his aspirations. So definitely any prediction, which is long-term prediction, will obviously be biased. But all predictions are like that. I think my predictions also, my wishes are also basically like that. I thought I would take this 2051 on these 4 counts. There is 4 pillars. One is education and prevention of burns. And next is the quality of the acute burn care. Third will be rehabilitation integration into society. And the 4th pillar will be the teaching and training and research. And these are things as the 4 conditions as to how we would be when we grow up to 2051 and what we could be. Or what you say in Tata's, they say, the India that she could be. I think that's an aspirational goal statement. The predictions for the incidence of burns, I am 100% sure it will go down. I think this is on the way because you will find even now there is a decreasing trends in terms of burn admissions to major centers. I think that's true. It's a welcome thing. Social media itself will influence policy changes. For example, the firecrackers. So it all go down. And there will also be global economic pressure if you don't agree to safety norms. I'll give an example for this, how a global economic pressure could drive down policy in our country too. In 1991, when we started our center in Coimbatore, the profile of our hand surgery patients was every day I used to treat hand injuries from textile industries and carding machines and blow room injuries. It's all because of inexperienced labor and not other than employing child labor. But then there came up some few articles in the Western media from where these things are sourced. They said, look where your shirts are being made. And then they took a picture where they have child labor and all put, and then there's so much pressure on those companies, otherwise the companies got closed down. He said, enter the multinationals, and they put the pressure on the media, and they said, if you do not set yourself right, we are not going to buy. So modernization of machinery immediately started, total abolition of child labor. I know all of them put boards saying no child labor is employed in this place. Total abolition of child labor, inspection of accident registries, and quality of care for the injured patients. Overnight, I think most injuries in the textile industry stopped. Now, I'm just wondering why we couldn't have done it ourselves. I think that's the sad part of the story was why we couldn't have done it ourselves. I'm sure such things will happen in burns too. Improvement in housing, improvement in electrical power transmission. I think no longer they will have overhead wires. I think wires which is almost near the houses and all that. I think they'll all stop. I think they'll all come down. Restriction on the sale of chemicals. But then the speed of change will depend upon the presence of champions and the presence of leadership. I think both political and I think the medical side. I think the history of the change of the level of the medical and the political leadership commitment, I think. The second part is that quality of acute care. I think here we're spending a lot of time. Where we go will depend upon the goals we set for ourselves. I think everybody is free to set your goal. You can really set whatever you want to do. It's a question if you want to make incremental improvement or reach the stage where the world's best are. I think that's a choice. I think you have to make that choice. And the good goal to keep, I think, for anybody, I think it's a statement given by Dr. Smith, a noted hand surgeon from the Mass General. He said, today's patient must get the best that today has to offer. I think this is what I keep for every subspecialty we start in Ganga. So this does not tell the best that your city offers, the best that your country offers. It just tells today's patient must get the best that today has to offer. That means that today it could be anywhere. I think that's what it matters. That's what it means. But then where are we? And how far are we away from that goal? So this is the table code which is taken by, not from the journal, but the entrance book. You will find in the decade between 42 and 52, and 88 to 91, 92 to 2004. So you find in the LA 50, which has reached in about 99% for age between 0 to 14, as early as 2004, 20 years ago. And you will see a gradual increase in survivorship. But then, do we have such records in India? We do not have. But then obviously in our minds we know we are far away from what we are having. I think this is it. And if you say this 40% survival rate has increased, if you find why they increased, you will find in the 1950s, the antibiotics, then later fluid management, wound management, and burn from early debridement. So they're all coming up in 70s. Nutrition, skin substitutes, and then the graph goes on. And that allowed the mortality rate to come down. And then if you take the article by Hendren in 2004, that is more than 22 years ago, it said it has been increasingly argued that using mortality as an endpoint to access advances in burn care is losing validity because of reduction in burn-related deaths. It has also said in future, long-term metrics that strengthen survival, such as restoration of growth in children, mental and functional status, quality of life, or the quality adjusted life years will likely gain even more traction and as powerful endpoints. So now, I think we should really stop thinking about now what's the death rates that have been there. So where do we stand in India? You find there are certain articles that have been found in 2008 to 2016. The mortality rates above 40%. In some other places, it has been as 94%. I think it is really surprisingly been shocking. But then where did the change occur and what time frame did the change occur? You find 1968, I think George Jansovik was doing her surgeries, and she published in 1970. That is 56 years ago, I think, which is about almost the lifetime of a working surgeon. 56 years ago, she said, a new concept was the early excision and immediate grafting of birds. Somehow, I think we in India didn't take it up with enthusiasm. I think that's the big mistake, I think the big thing which we did. It's all very established that deep burns need early surgery. It reduces inflammatory mediators, it reduces metabolic derangement, sepsis, and early excision is now kept as the standard of care in most major centers. But then now we have been slow to catch it up. See, for example, if somebody gets a thumb amputation, the standard of care is replantation. We don't say that means replantation is the standard of care in America, but then it's not for India. That is the same. I think for a person who has got an end-stage liver failure, liver transplant is a standard of care. But we don't say that it's not for India. I think that has to go. And there are a lot of evidences for it. And then if you really see the resources, what it really needs is not in material cost, it's in people. I think it's not in material cost, it's in people. I think that's where making it as a question of togetherness, I think that's where we miss. Let's take what happened in other specialties. The first laparoscopic cholecystectomy was done on September 12, 1985. The first laparoscopic cholecystectomy by Professor Utwadia in JJ Hospital on May 31st, 1995 years. So when it was happening, I was in the United States. At the time I was doing my fellowship in the United States, we were all looking it up. That's the big thing. But by the time we came in 1993, 94, in 5 years, the whole of India was doing it. The whole of India was doing it. We take microsurgery. So when you are doing our fellow, when you are training in 83 to 85 in Stanley, we had a Converse as the book. The one volume was on microsurgery. They used to tell us, you don't need to read this. Okay? And then even in the exams, they said, one of the things that you have a lower limb defect, you need to tell cross-leg flap. If you really want to fail, you have to tell microsurgery. You have to tell cross-leg flap, and you have to do it. But then some of us really thought, why should this difference be? I think those people who of us thought, Abraham, Tom, myself, Jai Kumar, I think some of us who thought, why should this difference be? Okay, suppose if you want to fly, we don't buy our planes from the corner shop, we fight from Boeing. So when it's like that, why not? I think those people who did the early stages got it in. Now it comes to robotic surgery has come in. So we don't say robots are not for India. But liver transplants are coming up. I think what we should think, liver transplants cost us about 20 lakhs. My son always tells me about you have to make a concept to people that 50% burns or a 40% burn, 50% deep burns is equal to doing a liver transplant. I think that concept we need to boldly and should drive it down. So if we have to offer the best that 2051 would offer to an Indian, I think we need to catch up. The question is it possible? I think the book by Richard Bach will say, you are never given a wish without also being given the power to make it true. But the next line is very important. You may have to work hard, however. I think that's what is very important. So why I say this, we can do it, is because of our trauma experience. So the same thing was in trauma. I think in 1991, you think back about 35 years ago, it was the same. For example, this child has come with a major head injury, and also has got a really crushed, I think it is from the axilla, I think from the clavicle to the fingertips, it's all crushed, it's not viable. It requires the things that what you do for the head injury, in addition to that, long vein grafts, the fixation, debridement, and the coverage of the vein graft, what we are used with immediately done a pectoralis major myocutaneous, pectoralis major flap to cover, and there she is. But if we are not done that on day one, all those things done on day one, that means she will be left with the shoulder level of amputation. So this we have been able to do. That means because the trick is we put it all together. Can such good outcomes and burns happen in our place? I think that's the question. I was always convinced it was possible. But now I am confident it's possible. Because until a few years ago when we started a full-fledged burns unit in our place and decided that we will do what the best in the world do. That's it. Period. I think we decided that we will work till it works. I think that's what we did. And for example, this patient who come a few months ago, 25-year-old, with a 44% deep burns, sustained in an industrial accident. All 4 limbs affected, and the left flank and the abdominal wall has been affected. The arrival of the date of burns was 15/9. He arrived us on 16/9/25. On arrival, he went under anesthesia and assessment. Within 24 hours of arrival, there was a total burn excision, and the whole area, 25% of it was covered with mesh autograft. Allograft was 5%, and BTM was 14%. 7th day post-op, and anesthesia. Day 22 post-op, removal of BTM and skin grafting. And that's the photograph taken of a 44% deep burns, photograph taken at 8 weeks post-burn. So now we know it's possible. I think it is just possible. So now we have made it the standard of care. But where do we lose out when we take up recent advances? Where we do? We lose them when we take patchwork, we do it. We try to do things what is possible or what is comfortable to do, but not the whole thing. Then it will fail. It's just taking a menu. It's like taking a menu. I think if you have to take a menu, I think you have to take the whole recipe you have to take. It's not like you can add up something or this thing you can't do. So that there you could lose. What you need to do is from a heated operation theatre to a committed intensivist to dietitian, I think we need to have. I think if we have that, but then it's not exclusive to birth. See, how does the liver transplant happen? How does the kidney transplant happen? Nephrologists, urologists, intensivists, everybody collaborates. But here, why alone the burns we say that we cannot collaborate? So Ganga Burn Center when we started, it really took us about 3 years to get stabilized. I personally feel it's a mind game. I think it's a mind game and a willingness to do it. And when I was a small boy, one medical company, Hex, used to put an advertisement, and beneath it they used to put a line which really caught my mind. You can't remold a country without a little mud on your hands. I think unless we put up a little bit of our work, it's just not possible. I think we need to catch up fast on this if we have to offer the best in 2051. All of us, every one of us will have some outstanding results to show. Some 80% survival and all that. All of us will have. All of us will have a replant to show. But the question is, does every patient who comes with an application get replanted? Does every 50% come into your center gets tolerant? So the question is, all of us have to remember that one swallow doesn't make a summer. I think we need to get consistent results, and our LA team must match the best it does and go beyond. The most important requirement for that will be attracting talent to the specialty. See, I think that's a paramount responsibility of senior people like us in the profession. If you see the profile of the NABICON attendees, you will find majority of them will be above 50. And the rest there will be a high peak will be below 35. This below 35 are all companies, they are all residents, and they don't really matter. They are being exposed to what is being there. But not necessarily they will take the push to specialty forward. But then every specialty where the attendance, the peak is between 35 to 50, they are the drivers of change. You come to a hand surgery conference, you will find the majority of them between 35 to 50. You go to aesthetic surgery conference, where are they? The peak is between 35 to 50. But beyond 50, I think they are already gone. I think the professor has said all that. No, so you are need only lead. But you are not going to be the drivers of change. So understand how do we get this 35 to 50? And why does not this 35 to 50 not attend our meetings? That's because attracting to the talent to the specialty, they come to the specialty when they find that the quality of the results achieved in a particular problem is very good. And the challenge to achieve it is a great challenge. That means there is a great challenge to achieve. That means you have got a lot of work to do to get it. See, replant is not easy, but then everybody wants to do a replant. But then it is very challenging. But then ultimately when you get it, it's fine. So that makes it good. So making a 50% burn survive is difficult. You are able to do it consistently, then it's fantastic. That is good. In this role, I think the teaching institutions is paramount. I think the teaching institutions, I think particularly the heads of institutions, all of us must really think what they have to think. This was a word told to me by Professor Venkat Swami when I was there I was a small boy with him, and then I used to really talk a lot to him. He used to tell me that our hand surgery unit in Stanley must be the pride of the city. Once you have that's the pride of the city, we will have a lot of hand surgeons. So similarly, I think the teaching units must think that they rethink yourself. That means does our burn unit in the hospital, is it the pride of the institution? Is it a place of action? Then again, youngsters will come. Often it is said the economy drives choices, that's true. And then we have to prove that burn care is not a core surgeon specialty. But once you do that, I am sure a lot of people will come. I am 100% sure it will change. I am 100% sure it will change. And then when it changes, if plastic surgeons we are not up to the mark, I think we will lose out and somebody else will take it, and then we will start playing. I think we need to catch it up to make it the first mover advantage. The next point is that number of burn centers. I am sure the number of burn centers will reduce as the time goes on, because people will start expecting the standard of care. So when you start expecting the standard of care, that means it's a very demanding thing. So not all centers will do it. And it will not be easy to hide behind numbers. We can't be saying that we do so many burn cases, so many burn cases come to our center. It's become a matter of fact, what do you do with those numbers? So I always tell people that due to the demographic advantage, that India and China will have the maximum number of heart attacks, maximum number of anything. More babies will be born in India. Just because more babies are born in India, a fellow from UK or USA will not come to India to learn how to deliver babies. That is, they will not come. But then it really requires on quality. Those who cannot match or don't take effort to catch up will not survive. I think I could go on with the downloaders experience in maternal and childhood. It's extraordinarily good. The government has done well. They have done so well that they find the smaller institutions or private institutions, they find they cannot match up with the government. They are all closing down. If they are not really being up to the mark. Next is the last is the reducing the cost of care. I think this is very important. My prediction is that the skin substitutes will take over and become commonplace. And most of them, the cost will come down. I think the cost will come down, and here again we'll have a role to play. I think those of you, I think it's a very nice book, Gandhi at 150, I like Gandhi. So at the 150th birth anniversary, the book was published. There's something called as the Gandhi in Engineering. I think there's a book by Padma Vibhushan, Meshika written. So he's written a concept of more from less for more people and what has really changed and what will really change. And then he says that a lot of things have changed. And he has given an idea that serving the needs of billions of have-nots requires making products and services available at an ultra low level of cost, but the same level of performance. It's not providing trash cheap Indians. I think that's again, it's for India. I think it's not providing trash to Indians. I think that we need to provide exactly the same quality, the best of quality, or even better quality. I think that because your Indian people cannot afford bad quality, and bad quality of healthcare is not worth attaining at any cost. So the question what the article asked is, can we make high quality hepatitis B vaccine that is priced at $20 per dose available at a price that is 40 times less but not 40% less? Can we make a high quality cataract surgery to IOL available not at $3,000 but at a price 100 times lesser? Then this question was ably answered by Venkateswaran and Arvind this thing. They really did it. I think they made it about 100 times lesser, and then they threw open the whole thing to the world. I think what will happen is, if we do that, I'm sure it will happen. If somebody will do it, you will just think you have to see what happens to the rest of the world. You will find that major burn centers can't just survive by doing burns, because the number of major burns will reduce. I think the West you will see that. Number of burns, major burns coming to them are reduced, but then what would happen is they will take new diseases and they will fall. I think wherever there is a major skin loss, wherever there is a challenging wound cover to be given, I think they will all come into effect. I think the major burn centers will take care of the difficult wounds they take. The next section is, next pillar is rehabilitation, integration into society. I think here will be on the way to par with the world. Not necessarily because of our own skills, but our skills are extremely good. And now we are the leaders in the technique of reconstruction. I think that will continue. I think only thing is that how do we make it available to the masses? I think we'll have to make it available. I think that's also, we have found hope after 5 projects. We know how to make it possible. I think that will make it possible. But our goal is that the major deformity correction should not be necessary. I think if we do it with acute care, if we do it better, I'm sure enough that this major deformity correction is. And the last one is teaching and training and research. The world will also be marching on. I think not that we will only be marching, I think everybody will be marching. And if you read today's papers, I think it's a so fluid state that we live in. Watching the current geopolitical changes, introduction of artificial intelligence in healthcare, it's extremely difficult to predict. The leadership in position of India in burn care will depend upon the quality of political leadership in India, South Asia and Africa, and the speed of progress that happens there. It will also depend on the institutional leadership, whether they are positive, whether they are willing to get out of the comfort zone. And then you find education and diplomacy. I think what we need to do is we have to invest on teaching and education. And said, by teaching others and helping people around you to become better, I think you will become the leader. Bill Gates said, leaders in the next generation will be people who will be helping others to grow. This again we need to remember. I think the institution has to remember. So we published a book because we crossed over 3,500 surgeons visiting our unit, and we put in a small book, Experience in Excellence. And this is a map of the countries where from they come. 89 countries they have come, and 164 cities in India they have come. I think we should achieve this in burns too. I think we have to achieve this. For that, I think we need to provide today's patient, the best that today is to offer, irrespective of the social status or affordability. If it is possible, we will be able to. The last few slides, I think I put it. So, the Indian Foundation of Quality Management is one thing which has come up. It has been founded by the industry leaders who have come. And what they said was they kept three things. They kept nation first, institution next, and individual last. And they said if you put the nation first, I think you yourself as an individual will do that. So if you ask this is the last slide, I will find, if you ask me, what is the one thing that is crucial to achieving all that I have predicted or all of us wish, that one thing is to get bright young people to do once. I think that's the one thing that we have to do. And it requires only a handful of people. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you so much for your attention.